So we had a lovely update of the diagnosis, staging, and treatment of patients with gestational trophoblastic disease. Yeah, Shazia, it is just published 4 days back, right? And this is a new Irish update of May 2022 on the molar pregnancy. Now, when a new update comes, I want to teach you today not only the topic, but the way we have to learn. Because I know that the students who are coming to MRCPI, hardly 10% are raw, or 10% are the ones who are taking the exam for the first time, like the professional exam. Either these students are from MRCOG, or these students are from EPCOG, the European board, or these students are, from the local exams, like the fellowships of their own countries. So hardly I get the students which are very raw and they're taking for the first time. So definitely they've got some basal level. Thank you very much, Tehmina, my dear. Thank you. So hardly the students are who don't have the basal level. Now, if you have a basal level, what do I expect from all of you? My expectation is that you open up your MRCOG notebook. For example, Javeria, you, Talha, Kazi, my dear, yeah, all my European board students, you open up your previous notes and you add on the differences. For example, you take your red pen and you write in front of that, okay, this is the difference, and highlight that. I don't want you guys to make a new memory. Why? Because you've already made an effort on your past degrees. This is what I did for myself. I made my MRCOG notes perfectly, right? And then I made the changes for MRCPI upon it. So isn't it a better way rather than starting from like A, B, C and making absolutely a different notes and putting like 100% effort from zero again? Do you people understand my point of view? I will tell you exactly today when I'm doing this guideline, you people would understand. What do I mean to tell you in this molar pregnancy? And I promise that you do it for once only, you would never forget the GTG and the Irish. When I'm taking MRCT Part 2 session, I tell them, okay, the GTG says this, the RCPI says this, or the European board says this. Why? Because I've got comparisons in front of me in my notes, right? I want to teach you exactly what's the right way. Today, the topic is not a bigger one. It's hardly 10, 15 slides, but I want your approach to be perfect from day one. I want that we be very smart students from day one. It's not about like spending 2-3 hours on a guideline and then forgetting it. Whatever we are doing, we need to retain it, right? That's a perfect student. Now, what are we going to do? The first recommendation of this guideline says that ultrasound examination can be helpful in the pre-evacuation suspicion of complete molar pregnancy, but the definitive diagnosis is made by histological examination on the products of conception. Now, you tell me that this is 2022 May update. Is that different from the Green Top guideline? Javeria? It's absolutely the same as per the Green Top guideline. So we don't have any trouble. We learned this point. Okay, GTG says that ultrasound examination is the pre-evacuation way of diagnosis and the histological examination is the post-evacuation, and the word definitive diagnosis come in the single best answer, Shazia. Yes, Kia, the definitive diagnosis if they're asking for in the single best answer, that's the histological examination. So it's absolutely same as RCOG. No need to burden your neurons for this, okay? Laboratories examining the products of conception should have an access to P57KIP2 immunohistochemistry to aid the differential diagnosis of complete, partial, or the non-molar pregnancies. The Green Top guideline also tells us, and this is your famous Sir Andrew Sizer single best answer as well, that says that P57 immunohistochemistry, that does a differentiating point. However, they say that as a recommendation, they do say in GTG that it should be done. However, RCPI makes a very strong grade of recommendation for this, that all laboratories should have an access. So the recommendation is an Irish guideline. The point is mentioned in the Green Top guideline as well. Do you people understand the difference? Here, it's recommended that when you're sending a product of conception, it should be to the laboratory who has the access of this immunohistochemistry. Do you people understand the point? It's a recommendation that that laboratory should have an access to P57. Am I clear? Did you people understand that how we have to pick up the differences from here? So PA57 is basically the immunostaining, friends, and that classifies the lesions and immunostaining that's absent in the complete hydatidiform mole, and it is going to be present in the partial hydatidiform mole. All right, so this is how you have to make a comparison, and never in life I would be ringing in your ears and you people would not forget that. The guideline update May 2022 as per the Irish recommendation says that the histological assessment of material obtained from the surgical management of all failed pregnancies is recommended to exclude trophoblastic disease. And it's a strong grade of recommendation. Now, they add on to this by saying that all women undergoing medical management of miscarriage or medical termination of pregnancy should be advised to perform a follow-up urine pregnancy test 2 to 4 weeks after miscarriage and termination. Now, where is the difference? I have given you the permission to be unmute. Can somebody tell me that is it absolutely the same, or do we? Thank you, Rania. That's my girl. Love you for very keen knowledge. Thank you, Muna. The Green Top guideline says 3 weeks. Very well done, Talha. Very, very well done. What about the first recommendation 2.2.1.1? What about the first recommendation? Is it the same? What do you guys say? What about the histological assessment in the Green Top guideline? This is specifically both of them in RCPI. Why? Now, how we have to train ourselves. Today, I'm telling you that I'm not only covering the topic, I'm telling you the way to study MRCPI, right? Now, if you go to the Green Top guideline, it says, and I quote from the Green Top guideline, that the histological assessment of material obtained from the medical or surgical management is recommended only if no fetal parts are identified. So what is the buzzword? Do people understand? The GTG says if no fetal parts are there, then only we are going to send. And the Green Top guideline says that urine pregnancy test following a miscarriage would be 3 weeks after the miscarriage. Now let's go back to the Irish recommendation, friends. What does the Irish recommendation say? The Irish recommendation say in this situation that we are going to have the recommendation in terms of the histological assessment, and this histological assessment is material obtained from the surgical management of all failed pregnancies. It is going to be sending there. All right, okay. Now it's also 2 to 4 weeks given. 2 to 4 weeks given, and in the RCOG they say 3 weeks. Okay. So please remember this for exam. This is how we are going to understand that this is the important part, and this is how we create the difference. Okay. All right. Now you people understand that it is a situation where we need to make a comparison. All right. In this, we have to make a comparison of the Green Top guideline, the recommendation, and we have to make a difference that what the Irish guideline says. In cases of suspected molar pregnancy, a pathology report should be available to the clinician within 14 calendar days. Okay. Now you tell me that where in the Green Top guidelines something like this is written. All right. Where is it written that it should be 2 weeks? It is given in the strategy, but we don't have this at all in the Green Top guideline, right? In case of suspected molar pregnancy, a pathology report should be available within 14 calendar days. So this is something which is recommended by RCPI. They say if the molar pregnancy is suspected, the requesting clinician should indicate their clinical suspicion on the pathology request form, and they should inform the pathologist as well. Thank you, Muna. These are additional recommendations as per RCPI. If molar pregnancy is suspected, the requesting clinician should indicate their clinical suspicion on the pathology request form. So please keep a note of that in exam. The guideline development group recommends that all women with suspected gestational trophoblastic disease should be registered, and with the National Gestational Trophoblastic Disease, that's registry. Now, this is also given in the Green Top guideline. Very good, Rania. Very well done. Now we understand that in this situation, same recommendation. So you don't need to burden yourself. It's not going to be a burden because you people understand that this is the same as that of RCOG. Okay, perfect. Now the human chorionic gonadotrophin, that should be measured using an assay that is CE marked for oncology. Don't worry about this because it is something which is a standard, which is done for any sort of a treatment that's being done as per the onco, right? For patients with complete hydatidiform mole, the serum HCG is monitored weekly until the normalization is achieved for 3 weeks. Here, I would like to have, thank you, Talha, perfect, London, Sheffield, and Dundee. Here, I would like to take your attention, please. If you people remember, and if you remember my molar pregnancy session of MRCOG part 2, I tell you guys that this is the gray zone in RCOG. They don't tell us that how frequently we need to do human chorionic gonadotrophin. Do you people remember? This part is short of information in RCOG. Yes, we do take it from the strategy, but we don't have it in the Green Top guideline that how frequently we need to measure HCG. However, they do say that if it within 8 weeks, it becomes normal, then yes, the follow-up is going to be the 6 months time, right? Post-surgical evacuation. The recommendation 2.2.6.1 that says that HCG is monitored weekly until the normalization is achieved for 3 weeks. What does it mean? In single best answer, if they say that today the evacuation has been done, so for the next 3 weeks, how frequently you're going to do the serum beta HCG? And this is a very common question of our CPI, where they want you to know the follow-up of the hydatidiform mole. So how frequent you people are going to select in the single best answer? Very well done. Javeria, weekly for how many weeks? Salma Osman, weekly for how many weeks? 3 weeks. Very well done. Now, if within 8 weeks post-evacuation, then it becomes normal, then monthly for the 6 months. That means 4 weekly. And if it becomes normal after 8 weeks, then monitoring is 6 months post-normalization. Now, the 6 months thing is absolutely same as that of the Green Top guideline. Do people remember the Green Top guideline recommendation that within 8 weeks, if it's normal, it would be 6 months from the time of evacuation? And if its normalization occurs after 8 weeks, then it's 6 months from the day of the normalization. Do people remember this? Thank you, Rania. 56 days or 8 weeks as per the Green Top guideline. However, this weekly recommendation is different. Now, there's a few new terms. Students, they tend to get confused on this. CE marking is simply, it appears on many products, friends. And that basically says that it's an extended single market in the European Economic Area. And they signify that products are sold in having a standard. Okay, so that's an environmental protection requirement. Whenever they use this word, don't get confused with this. This is a standard word for keeping up a good standard for this protocol. Okay. The next recommendation says that for patients with partial hydatidiform mole, the serum human chorionic gonadotrophin should be monitored weekly. Now, this again is different because this weekly thing is not given in the Green Top guideline. The Green Top guideline does not tell us that it's going to be something weekly for us to be checked in exam. However, until normalization, it's weekly. So what is the rule of thumb? For this, we need to remember for exam that whenever they say weekly, that is until the HCG gets back to normal. So until and unless it gets back to normal, it would be weekly beta HCG until normalization. And the day it gets back to normal, after that, it's going to be 4 weeks, another confirmatory test. So this 4-week things, if somebody has done the updated Green Top guideline, you all know that this 4-week is the recent recommendation in the new molar pregnancy. Have you people read that, please? Have you people read that, please? Yes, Preeti, very well done, my dear. Thank you, Shazia. Thank you, Muna, perfect. So I repeat that once again, that it's going to be weekly, weekly, HCG, the day it gets normal, then after 4 weeks, a second HCG and the partial follow-up is complete. Amber, is it clear? Yes? Rayana, is it clear? Exactly, Javeria. Very well done. Why? Because we didn't have this part in the Green Top guideline. Perfect. Okay. The HCG testing should be centralized in women with a confirmed gestational trophoblastic disease registered with the National Gestational Trophoblastic Disease Registry. So please keep a note. The ones which are same recommendations, just keep on being there in your notes, and the different ones you're going to highlight. Now, the FIGO registration in terms of the scoring and doing the chemotherapy regimens, that is the same. The gestational trophoblastic neoplasia, the same FIGO score we are going to take from the Green Top guideline, that is the same. And the indications are given in the strategy. They're not given in the Green Top guideline. If it's a plateau or rising human chorionic gonadotrophin, if it's a heavy vaginal bleeding, if it's a histological evidence of choriocarcinoma, the evidence of metastasis in brain, liver, or gastrointestinal tract, or the radiological opacities like more than 2 centimeters in the chest X-ray, these all would be given. And in the single best answer, we would select the chemotherapy. Now, I would like to ask a question here. How many of you remember there was the cutoff of FIGO for a single agent or a multiple agent chemotherapy, please? Muna, Rania, Amber, Preeti? Thank you, Shahina, my girl. Very well done. Very well done. So it is very clear that it should be less than 6 or Talha 7 or more. Talha, please message Sumaya to join in. She asked me to remind her, my dear. She might have forgotten. Please message Sumaya. Huh? Thank you. Okay, women who have raised HCG 6 months after evacuation with a falling HCG should have treatment plan discussed with the National Gestational Trophoblastic Disease. Now, it's a different recommendation here, that if HCG is raised 6 months after evacuation with a falling HCG, this is a very, very important point. Why? Because in Green Top guideline, this point is not touched. A patient is there and she is having a follow-up. You all have to understand this point, please. She is having a follow-up and HCG is falling. So we are happy that the HCG is falling, right? But she still have raised. I mean, not coming back to normal till 6 months after evacuation. So that is an indication that we have a chemotherapy discussion with the National Gestational Trophoblastic Disease Registry. Okay. At the same time, if 4 weeks have passed in the follow-up, friends, 4 weeks have passed in the follow-up, and the beta HCG in the exam question of your single best answer, that stays 20,000 and more after evacuation, right? Again, that needs to be discussed in the National Gestational Trophoblastic Disease Registry. So I repeat this recommendation again, please. I hope you all understand. This is if it's persistently being raised, no matter it's a falling pattern, but if it's raised in 6 months, not coming back to normal, or in 4 weeks, it's equal or more than 20,000. That is going to be discussed in the National Gestational Trophoblastic Disease Registry. What do we need to do for this patient? Because it's a high-risk patient. You all are absolutely right that FIGO score of 0 to 6 can be a single agent methotrexate with or without folinic acid or actinomycin D. Now, taking into account the treatment cycles, we are going to check as per the agreed protocol. In MRCPI, they don't want you to test for the very typical or the basic or the very strong questions of the chemotherapy. They don't want you to know the regimens, but yes, you should be knowing that when to give what, like in terms of scoring, right? So 0 to 6 would be single agent. And they say that chemotherapy for low-risk disease should be like continued for 3 cycles of consolidation treatment at a standard of 2 weekly cycle after HCG normalization. So a continuation of 3 cycles that should be done. Consolidation treatment is the basic, what we start with, the intensification when we start, not the maintenance, right? If at all the FIGO at the beginning is 7 or more, then the single agent would not be selected. Then it would be a multi-agent chemotherapy. And you all know the EMACO, the famous regimen for the FIGO 7 or more score, same as that of RCOG. In this condition, there are 2 additional recommendations which you all have to remember. When we were studying the Green Top guidelines, you people remember that we did only 6 and less and 7 and more, right? Have you people heard about 12 score cutoff or something like that? Does somebody know if the FIGO is like so high? If the FIGO is like more than 12, what's the difference? Do we have any difference, please? More than 12. Yes, Rania is reading. Yes, Rania? No? All right, I will tell you. They say that we have got an ultra high risk gestational trophoblastic neoplasia. And in that situation, they say that additional chemotherapy, it is there, and the deaths can be reduced by induction therapy with etoposide addition or cisplatin. Why? Because they say when the FIGO score is 7 or more, these are high-risk patients, so we require multi-agent. But if it's more than 12, these patients are ultra high-risk patients with early deaths potential, right? In that situation, the chemo start, that is the induction therapy, that would be with etoposide and cisplatin as well. Do people understand? They have made another category of ultra high risk of gestational trophoblastic neoplasia, which is specifically in our CPI. Are you all with me on this? Did you people understand that? What difference does it make? If they tell us an additional high category where we need to add additional chemotherapy, etoposide and cisplatin, right? And they say that even if it's a low-risk gestational trophoblastic neoplasia and you have started off with the first-time chemotherapy, the first and the second course of the chemotherapy, that has to be inpatient. I repeat that once again, Preeti. Preeti, for example, Rania, for example, you get a single best answer in exam that a patient has got a 6 or 5 FIGO score, right? So what is going to be the chemotherapy of choice in exam, please? What are you guys? Thank you, Rania. Perfect, my dear. For FIGO more than 12, etoposide and cisplatin, right? Okay. So my question was to all of you out there that if it's going to be less than 6, what is going to be the answer for the chemotherapy selection? Talha, Rania, Preeti, Rubaba, Muna? Less than 6. Yes. Tell me the name. Methotrexate. Perfect. Now, if they give you methotrexate outpatient, methotrexate inpatient, and there are 2 options, Talha, what would you guys select? Now you understand that have the single best answer, they're going to play around with the words only. Outpatient or inpatient? See the recommendation 2.4.4.1. See the recommendation 2.4.4.1. Now everybody would start changing the answer. I knew it. Did you people see? They recommend now that at least first 2 courses, they should be inpatient. No matter their low risk. Very well done, Shaista. Very well done, Javeria. These are the updates. Now, you people will put a stick on your molar pregnancy and just write these one-liners. Right, Shazia? Do people understand why am I telling you like it's not different? The first time it's going to take you 30 minutes, but you will never forget in future. All right. And the monitoring with the chemotherapy as per the Irish recommendation is basically by the HCG. And when the HCG gets back to normal, so 3 further consolidation cycles, the intensification cycles are being done further after getting normal, please. So any patient who has the HCG levels measured prior to the next chemotherapy cycle and should have 3 cycles after the HCG normalization. So if at all these patients are poor prognostic features they're having, these 3 cycles would further be extended to 4 cycles. Example, if today the HCG gets back to normal, if a normal patient, low-risk patient, or the patient who is like otherwise having high-risk factors is there, 3 cycles further we are going to do. But if it's a poor prognostic cancer, like that of liver metastasis, with or without the brain metastasis, then instead of 3 cycles, the extension would be 4 in the exam, right? I will go back once again for Rania, please. Rania, my dear, please have a look. Rania, just above the block, the RCPI here. Got it? Okay, perfect. Thank you very much. All right. Okay, so remember that for poor prognostic cancers, instead of the consolidation 3 cycles after normalization, it's going to be 4 cycles. Very welcome, my dear. So what is the difference? Just for your information, it's not in the guideline because these words are repeatedly being used. So you should be clear that consolidation cycles are different from the maintenance one. The consolidation are intensification therapy, like which are started off, right? And the maintenance is after the remission to maintain the avoiding the recurrence, okay? Now, after the remission is achieved in a cancer, the serum HCG should be measured fortnightly for 6 months, then monthly for a further 6 months, and every 2 months for 2 years. Now, I have to teach you today, and till the last session, you people have to make notes in this way so that the memory is better. You never remember the follow-ups like that. You make your algorithms. How? Fortnightly, after the remission is achieved, the serum HCG, beta HCG would be done for after 14 days for the 6 months, right? Then we are going to do monthly for the next 6 months, and then every 2 months for 2 years. These type of algorithms, one-liners you people would make, because in the last 15 days, we would revise these one-liners. It becomes very difficult if you keep the paragraphs for the follow-ups. So today I'm making you learn the exact way of learning and passing in one go. So this is going to be the right way where you are going to make your one-liners so that in last 15 days, we know that, okay, follow-up of everything is to be revised. We have our follow-ups in the form of algorithms. You will never forget for the single best answer. And these are different from that of the Green Top guideline. That's why I'm coming up with these recommendations. And even for the OSCE students, molar pregnancy is such an important case to come, both as a structured discussion in the examiner circuit and also for the long case viva as well. Okay. Now, there can be a possibility for the low-risk patients who have their FIGO scoring less than 6 or equal to 6, but still they're not having the chemotherapy selection as the best one, like the first line chemotherapy. Why? If they have, for example, the treatment-related toxicity, or for that matter, the HCG in the 2 successive measurements 1 week apart is either rising or it's like a plateau, it's not getting lower down. So that means that this patient is not having the suitability for the first line chemotherapy. So this is the indication of the change in treatment of the first line chemotherapy. How does the question come in exam? The question comes with an age of a patient, and she has been diagnosed with low-risk gestational trophoblastic neoplasia. She has a score of 6 and she is started on the first-line chemotherapy. So she is having the features of the side effects or the toxicity, for that matter, of methotrexate. Or they give you an exam that in the successive measurements 1 week apart, the HCG levels are getting rising or they're plateau. So the answer would be, please change the treatment from the first line chemotherapy. Do people understand? The indications of the change of the treatment for the first line chemotherapy comes like this in the single best answer. So you should be knowing what are the indications of changing, despite she is a patient who has the first line, but you people should be knowing. So if you learn the guideline this way, there would not be a single point in the single best answer. You people would miss out. A wonderful update in May 2022, which is not in our COG, is regarding the HCG levels and the methotrexate. I need your attention, everyone. There should not be any multitasking at the back. Please give me all your attention for next 15 minutes, and then we are going to wind up, okay? For women with low-risk gestational trophoblastic neoplasia who have not responded to methotrexate, who have the human chorionic gonadotrophin less than 1,000, the next line of treatment is actinomycin D. Now, Shazia, Rania, Muna, Amber, what do they give an exam, Preeti? They give an exam that the patient is having a score. When they say low-risk gestational trophoblastic neoplasia, that means that they're talking about the FIGO scoring 6 or less, okay? So when they say that the score is 6, methotrexate has been given and HCG is raised, right? So if HCG on the successive test is raised, we did just in the previous recommendation, that's an indication of changing up the chemotherapy. Do you all remember? I just told you 3 points of the indication of changing the first line. Yeah, just in the previous slide. Perfect. Okay. Now you need to see the HCG to see what's going to be the replacement. If the HCG is less than 1,000, then it is going to be actinomycin instead of methotrexate. Very well done, Rania. And if they say that she has not responded to methotrexate, the HCG is persistently raised and the value they give you more than 1,000, then you people will choose the next line as a combination EMA-CO. Do you people understand? This is all update in our CPI. We don't have it in our COG at all. But these are the questions that will be coming up in exam. Why? because it is only the Irish recommendations which give us these changes. We don't have these changes. So I'm going to highlight these changes. Otherwise, 70% of the curriculum would be the same, right? And this is just like a week back publication. So less than 1,000 being raised, actinomycin, you people would select an exam. Thank you, Preeti, my dear. And if it's going to be more than 1,000, it would be EMA-CO, right? Okay, that's perfect. Similarly, if they have a relapse and sequential single agent treatment is also not beneficial, then it has to be a combination therapy. I repeat that again. What do they mean by that? Okay, let's go back. That if it's a FIGO scoring, you have to answer me here, please. If the FIGO scoring is 6 or less, what's the first line? Come on quickly, please. What's the first line in exam? 6 and less, FIGO scoring. Perfect, methotrexate, all right. Methotrexate has been given, and in the successive weekly HCG is raised. What is going to be the next step if it's raised? The change of the chemotherapy, right? Yeah. The beta HCG is less than 1,000, but it's raised, persistently plateau or raised. So what's going to be the alternative to methotrexate? Very well done. Actinomycin D. Now I say that actinomycin D, she has not responded to actinomycin D. She still has a relapse. What would be the next step? Thank you very much. If she has not responded to the second single line agent, we would go to EMA-CO. The difference would be that we won't choose actinomycin D in exam if directly HCG is more than 1,000. Then directly we'll go to EMA-CO. But if it's less than 1,000, first step would be actinomycin D and second is going to be EMA-CO. Would I make myself clear? Do you find it easy now, like in a systematic way we are learning together? Yes? Perfect. Okay. Now, any patient who is not low risk, who has from the very start the high-risk gestational trophoblastic neoplasia that is going to be more than 7 or more, then first-line treatment we know is EMA-CO. The next is going to be etoposide added, right? So we don't have a single agent, of course. We are going to have another second-line combination chemotherapy to be used. Why? Because in high-risk patients, 7 or more FIGO, we don't go with the single agent. We are going to have a replacement of a second line. So here we use the paclitaxel and etoposide instead of EMA-CO as a second line agent, please remember. Coming to the last few algorithms, which I love it because we don't have an RCOG. However, RCOG tells us the same. I was doing this from MRCPI and I thought I will be using this in my MRCOG session as well because it's beautifully given in terms of algorithm, which you people already know. So let's start because the single best answer comes from this. Patient with complete hydatidiform mole. So what is the treatment of choice? This is your first single best answer of exam. Thank you, Shaista, my girl. Thank you, Fatima. Evacuation, suction evacuation. Now my question is, I'll go stepwise, right? So you know that how the exam question comes. Second step is after evacuation, how frequently you people are going to do the beta HCG. This is the second single best answer they'll give you in a scenario. Very good, Rania. Weekly. Until the normalization for 3 weeks. Perfect. That's like my students. You all are awesome. If normalization is less than 8 weeks, what would be the follow-up? This is your 2018, 2019 single best answer. 6 months from the date of evacuation. If at all the normalization is after 8 weeks, then Preeti, Amber, Minahil, yes, it's going to be monitoring for 6 months post-normalization. Perfect. You people are great and you are such a quick learner. You people are going exactly the way I want to train you guys for the MRCPI from day one. If at all, they give you a single best answer for the partial mole. So the drug of the method of choice for the treatment, we know is evacuation always, right? Monitoring serum beta HCG would be again, as we did in the complete molar pregnancy. And what's that? Weekly, right? Until normalization. And the day it becomes normal, what are we going to do? In a partial mole, Fatima? Muna? Thank you. We are going to do 1 HCG confirmatory, an additional one 4 weeks later. Perfect. Hats off. Thank you very much. So we did it. This was May 2022 molar update. See, again, if you see this guideline, maybe out of 20 recommendations, 5 recommendations were newer one. So you just have to put up those 5 stick-ons on your molar pregnancy, and your MRCPI recommendations are done with your MRCOG only. Do people understand? This was just a glimpse of the preparation way which we are going to do. Definitely, yes, Shazia. You just tag Binte Hawa Myra, the moderators, please, or tag Safa there. You're just going to put that in there. Okay? It has not been told, Javeria. If the question comes, we are going to take it from the Green Top guideline. Now, Javeria's got a very beautiful question here, friends. Anything where our CPI is short of recommendation, we pick those recommendations up from the Green Top guideline, the talk articles, or the NICE guideline. Anything where we have the recommendation of the Irish guideline, we give it priority over the Green Top guideline recommendations. I mean, where it is a tie, where it is a clash, we prefer our CPI. And let me tell you, whenever there is a clash, 100% that question comes in exam. Because that is the differentiating point. Like, students have read those guidelines. All right. So whenever there is some comparison in the recommendations, we do the RCPI guidelines. And we prefer that recommendation for exam. Those differentiating points. I mean, those out of 20 recommendations, those 15 points are not very important, but the 5 differences are very, very important. Do you people understand the approach towards the MRCPI preparation? Do people understand that how we are going to make it easy? Now, no, Shazia, it's not like that. We would be reading all those Green Top guideline topics, the NICE guideline and the talk articles, which are not in the recommendations of the Irish source. Yeah, so we are going to do that. Sure, Talha, my dear. Talha, this one? Yeah, where I did the types of the chemotherapy, right?
Yes, doctor. Yes.
Thank you very much. Thank you, Talha. Preeti, talks, I'm going to give you a 20 list. They have to be done only. And all these summaries of the recent ones, just in the recent exam, I'll share that exam with you guys once like we start the session module wise. In every, for example, gynecology, I'll do the recent questions with you, the recent exam questions. You people would understand that there are certain favorite talks and they just revolve around those talk articles. All right, Tala, it's nothing. It's just like taken from the Google. This, what is this EMA EP, etoposide and TETP? That's it. Okay, I'm giving you that. What is the addition? If EMA co is not working, what is the second line? Got it? This is the chemotherapy. Javeria, we will do. Even 2021, we will also do, my dear. No, 2021, 2022, we will do because 2-3 new questions of the talk articles were there. Okay, so all the paid students, the complete single best answers would be available with you guys till 2022 from each talk article. The SP is made from the lines of the talk article by ourselves. Okay, that would be part of your portal. What you'll do is that you will do the talk and then you will see its question so that you analyze yourself. All the CPDs solved till the year 2022 would be part of your portal because that book is separately being sold to the open students, but the core students have its access. So what you'll do is at least all the CPD questions you people would solve, and it's in the form of a book and that's super easy to scan. All right, so you people would love it while just scanning in the form of a booklet online. So don't worry about that. All right, okay. Yeah, so what would happen is that you people would just scan the CPD questions. You people would understand like the basic points and the single best answers as well. Would that be okay? Right? Okay, Preeti, same, my dear. You log into the site. Same as you people already do, where all the Green Top guidelines, the sessions are going to be. Shazia, we're going to do only those Green Top guidelines which are not touched in the recommendations of the Irish guidelines. And I will tell you module-wise. Module-wise, we are going to do. All right, got it, please?